is to launch a set of publications that have been developed under the UN NCD Interagency Task Force that call for urgent action on NCDs during and beyond the pandemic. First, we call for the voices of people living with NCDs to be heard in all discussions about policies that directly affect them. Second, we call for global financing instruments to be extended to low-income countries that request support for non-communicable diseases. And third, we call for constructive dialogue or partnership with the private sector. Because people with NCDs are at high risk of severe COVID-19, finding effective therapeutics for these patients is a high priority. Earlier this week, WHO issued new guidance on the use of corticosteroids to treat patients with severe COVID-19. Evidence shows that corticosteroids can be life-saving for patients on oxygen and ventilators. However, corticosteroids do not help patients with mild or moderate disease and can be harmful. WHO therefore recommends the use of corticosteroids only in patients who are severely or critically ill. These guidelines combine the highest scientific standards with the urgency needed to respond to this pandemic. Providing guidance on therapeutics, diagnostics, and vaccines is one important part of WHO's work. Ensuring access to those products is another. In the coming months, we all hope to have good news about a vaccine for COVID-19. But if and when we have an effective vaccine, we must also use it effectively. In time, as production increases, we want all people everywhere to have access to vaccines. But initially, when supply is limited, priority must be given to vaccinating essential workers and those most at risk, including older people and those with underlying conditions. In other words, the first priority must be to vaccinate some people in all countries rather than all people in some countries. This is not just a moral imperative and a public health imperative, it's also an economic imperative. In our interconnected world, if people in low and middle income countries miss out on vaccines, the virus will continue to kill and the economic recovery globally will be delayed. So, using vaccines as a global public good is in the national interest of each and every country. Vaccine nationalism will prolong the pandemic, not shorten it. The Kovacs facility is the agreed international mechanism for ensuring equitable global access to vaccines. It is solidarity in action. Kovacs guarantees access to the world's largest portfolio of vaccine candidates. Our partner, the Coalition for Epidemic Innovation and Preparedness, CEPI, is supporting 9 candidate vaccines that will be made available to the facility, 7 of which are in clinical trials. We're also in discussions about 4 other promising vaccines. Another 9 candidates that are in earlier stages of development are being evaluated in the facility. We're delighted that 78 high and upper middle income countries and economies have now confirmed they will participate in the Kovacs facility. And the number is growing. I urge those who have not yet joined to do so by the 18th of September. I would like to thank those countries and economies who have announced publicly they're joining Kovacs this week. Germany, Japan, Norway, and the European Commission. Vielen Dank, arigato gozaimasu, takshka duha. Of course, many more countries have joined, and we look forward to being able to share the full list in due course. Although we still face many challenges, WHO is encouraged by the progress we have made against this new virus in 8 months. With national unity and global solidarity, we can and will end this pandemic. I repeat, with national unity and global solidarity, we can and will end this pandemic. I thank you.
Thank you, Dr. Tedros. I will now open the floor to questions from the press, but I would like to remind first that you need to raise your hand. Use the raise your hand icon in order to get in the queue to ask questions. Also, remember, we have a large number of you in the queue, so please stick to one question. The first question is from Agnès Pedrero from Agence France-Presse. Agnès, please unmute yourself and ask your question. Agnès? Agnès, can you hear me? No. Agnès? We will come back to Agence France-Presse later on. Now we have Anna Pinto. Anna, can you hear me? Please don't forget to unmute yourself. Anna, can you hear me? So we can have some technical problem, but trying again, Anna or Agnes, can you hear me? So if we cannot have Agnes or Anna, I will go to Gabriela Sotomayor, Mexican journalist. Gabriela, can you hear me? Really? So let's see how we can fix this problem. Sorry for that. We are trying to fix the technical problem. So let's try once again. Agnes, AFP? No. Yeah. Yeah. If you cannot hear me and speak, please type your questions. We will receive them. Thank you for your patience. Okay. Yeah. So, hello. Gabriela, Anna, Agnes, can you hear me? If not, we received a question from Gabriela Sotomayor from Mexico, journalist from Proceso. I would like to know if you agree with the call made by Amnesty on accountability, and if you can say how the rights of health personnel can be protected. They are exhausted, the pandemic continues, it has not stopped. How to help them? Many work in terrible condition, and they are fired if they complain. So who will take this question? Dr. Maria? Thank you.
Yes, thank you very much for the question. Just checking if people can hear us. So thank you very much for this question, Gabriela. You know, healthcare workers are our frontline workers and need to be cared for and respected and protected for the incredible work that they do on the front lines, saving people's lives from COVID-19 and from many other infections. So all healthcare worker infections are important. Even one healthcare worker infection is too many. So we have some information on healthcare worker infections by country, and it varies quite, it's variable, highly variable by country. And from the data that we have that's received through our clinical platform, through our case report forms that come in by country, it's anywhere between 8 and 27% of the reported cases. From data from our regional offices, this week, our regional director of PAHO noted more than 570,000 health worker infections in North and South America. And in the US and Mexico, healthcare workers account for about 14% of infections. Across our African region, it's around 5% that are healthcare worker infections. And if you look across the published studies, again, the data is highly variable. And if you look at seropositivity, which is evidence of infection through antibodies, healthcare worker infection ranges from 1.6% to over 31%, depending on the study. And if we look at PCR testing by study, it ranges from 0.4% to over 23%. And so what we understand about how health workers are getting infected, there are several studies that are looking at this, and we have a living systematic review that we are conducting where we are constantly looking at the literature. And some of the reasons why health workers are infected is because of a lack of PPE, not having adequate PPE to do their jobs, and in some situations not having the training to wear the PPE appropriately. And early on in the pandemic, when we have cases in some different wards, such as geriatric wards or other wards that weren't prepared for droplet precautions for infectious diseases, they weren't trained to wear the right type of PPE. That has been changed, and that has been improving. We also know that health workers are infected while on the job, when they're in rest areas, if between each other. So there's transmission that's happening between health workers. And we know that there are conditions in which they are working in where there's extended shifts, not adequate rest periods, that really needs to be supported. But we also need to remember that health workers are people too, and they live their lives. And unfortunately, many health workers are also infected outside of the healthcare facility. So I think there's a number of things that we are doing and that countries are doing to protect health workers. This is a priority of WHO's beyond the pandemic, but is a top priority of WHO's to protect health workers. We have guidance that is out around infection prevention and control, so how they can care for patients safely and the type of precautions that are needed depending on the type of care that's given. Our supply chain task force has worked very hard to ship PPE to 172 countries in all regions. Millions of respirators and medical masks, face shields, gowns, gloves, goggles. We've issued trainings for infection prevention and control to make sure that all health workers know what this virus is, know how it is transmitted, know what are the proper infection prevention and control measures that they can take. But we do need to ensure that health workers are equipped with the right PPE. And I think just lastly, we do need to do more to make sure that the right conditions are in place for health workers, that they have adequate rest periods, that they have psychosocial support. What health workers are going through is incredibly difficult, and we owe so much to them. And I think just lastly, we owe the respect to them, and there should be no stigma attached to the life-saving work that healthcare workers do.
Thank you very much, Dr. Maria. We have also in the room Dr. Bruce Aylward. He's the Senior Advisor to the Director General. He leads the ACT Accelerator, and he has something to add. Bruce?
Thank you to Fidela, and thank you especially, Gabrielle, for raising this important issue of just the stress that the healthcare workers and care workers in long-term facilities continue to be under in this crisis, because we cannot give it too much attention, quite frankly. And I think Maria has done a wonderful job laying out all the things that we're trying to do collectively through the health sector, the health organizations, to try and ensure they have the tools, the training, et cetera, to take care of themselves. But I think what we have to remember, Gabrielle, when you ask what else we can do, is going back to what the Director General General said in his opening comments, the single most important thing we can do is to collectively change our behaviors in the ways that are going to reduce the intensity of transmission, reduce the cases, and reduce the pressure on the health system. At the end of the day, that is the most important thing we do. We will look to our political leaders, we'll look to our health leaders to help address these issues, but we also have to look to us collectively, the general population, how we choose to work, how we choose to live, how we socialize. These are the important things that drive transmission. We've got to ensure we maintain the distance between people, the masks, and the other public health interventions, because ultimately that's what's driving transmission. That's what's putting the pressure on the healthcare system. But like you emphasized, most importantly, behind that system of people, right? It's the healthcare workers, the nurses, it's the cleaners in the facilities, it's the physicians, and so many others who work in these facilities that pay the ultimate price for the choices we make as individuals in terms of doing our part to reduce transmission. That is the most important thing we can do to help.
Thank you, Dr. Bruce Aylward. We will go now to Agnès. I was told the technical problem is solved. Agnès, Agence France Presse. Agnès, can you hear me?
Yes, I can hear you.
Oh,
Do you
welcome,
hear me?
Agnès. Just ask your question.
Okay, great. I will ask it in French. D'après les médias suisses, les chiffres ont montré qu'il n'y avait pas de surmortalité liée au coronavirus pendant le premier semestre de l'année. La situation semble être différente dans d'autres pays de la planète. Est-ce que l'OMS dispose de statistiques qui montrent une surmortalité depuis le début de la pandémie? Et est-ce qu'il y a des différences régionales?
Thank you, Agnès. Dr. Maria?
I can begin, and maybe others want to jump in. So you highlight a very important aspect of a pandemic or any emerging pathogen as this pandemic evolves. There are deaths that are associated, that are counted, that we know are associated with COVID-19 from infection and are tracked in real time as they occur. There are ones that we will be identified as we retrospectively look at, we go back in time and we look at deaths. And there are systems that are in place in several regions, in several countries that are looking at excess mortality. The one that I'm most familiar with, and there are others, is the one that's in Europe. That's the Euromomo project, which is looking at excess mortality over time. And as you point out, there are some variations in excess mortality by country. I think it's too early to make conclusions about this because this is something that is ongoing. But I think it is important to recognize that deaths from COVID are likely to be undercounted at the present time. But countries are working very hard to better understand this. We do also need to be looking at other causes of mortality that are occurring during the pandemic because people have not been able to access the care that they need. So it is really critical that we get essential medical services and life-saving services back online so that people who need the care that they need can receive it and can receive it safely. And so that is something that all countries are working very hard on. We are working very hard on to support countries to be able to do. But I think we will see some differences in excess mortality, and we are tracking the systems that are currently in place that are collecting that information.
Thank you, Dr. Maria. Dr. Bente Mikkelson would like to add something. Please go ahead.
Thank you. Thank you very much for the question. And as Dr. Tedros said, we have had several surveys which show that we have major disruptions in the case of non-communicable diseases, cardiovascular diseases, cancer, diabetes, and respiratory diseases. So far we have comorbidity studies from single countries, and we are working on this also at a global level. So of course, it will be very important to trace what you're actually saying, because we really need to know if this will again dwindle the achievement of the SDG 3 3.4, namely to reduce the mortality from non-communicable diseases. So we don't know this yet, but from studies we know, and the good thing is that the majority of countries have actually now started to register comorbidities in their hospitals. So we know that, for example, in Mexico, diabetes were the most frequent comorbidity in the registered deaths for COVID. And we see other figures like in Italy, among those dying in hospitals, we see 67% of people living with hypertension and 31% living with diabetes. So this is, of course, very important both for the current situation, but also to understand the picture and be able to close these gaps with the guidance that WHO can give. Thank you.
Dr. Bruce?
No, Agnes, you raised a really important point about this excess mortality data. And as Maria laid out, many countries do track excess mortality, not all countries. So we don't have data from all over the world. And as Maria said, it's actually tracked differently in some countries, so we don't have exactly comparable data. But what we do know very, very clearly is that there has been more mortality during this period than the numbers from COVID-19 alone tell us. And that's extremely important. Some of that excess mortality is probably COVID disease that was not recognized or reported, but then it's also telling us that this incredible impact on the health system that Gabrielle asked about earlier is having a real cost in terms of human lives. And this all emphasizes the importance of the measures that the Director General has just emphasized day after day after day, because there's a real cost in human lives that go beyond the numbers that we're seeing in the COVID numbers alone.
Thank you all for these answers. We will go now to India to ask Aziz Ahmed from Hello Mumbai. Aziz, can you hear me? Please unmute yourself and ask your question. Aziz? I was told he's no longer online. If not, we will go to Anna Pinto. Anna, can you hear me?
Yes.
Hi, Anna. Just ask your question. Thank you.
Okay. Earlier this week, the president of Brazil, Jair Bolsonaro, was approached by a citizen who asked him not to deploy vaccines against COVID-19 in the country because, according to him, and I quote, vaccines are dangerous. And Bolsonaro replied to him that the government will not force anyone to get vaccinated. My question is, I'd like to know what is the WHO message for people who believe that vaccines are dangerous, and what can be done to counterbalance anti-vaxxers movements and disinformation? Thank you.
Thank you, Anna. I believe this question is for Dr. Soumya Swaminathan, our chief scientist. Soumya, you have the floor.
Thank you, Fadela, and thank you for that very important question. I think this is really a topic that everyone around the world is discussing today. I think the first thing to remind ourselves is that vaccines are life-saving interventions. And if you think about diseases like smallpox, like polio, like measles, that used to kill hundreds of thousands and maim millions of people around the world, it's thanks to vaccines that we don't see those diseases today. So we've forgotten what smallpox is like. We've forgotten what polio is like. We've forgotten how measles kills, used to kill millions of children, still does kill hundreds of thousands of children, unfortunately, around the world, despite the fact we do have a very safe and effective vaccine for measles. So we have to put in perspective, vaccines and what they've done for humanity when we start thinking about COVID vaccines. We're at an early stage of development. No doubt that there's been an unprecedented speed of development of COVID vaccines. We've never seen anything like this before. And that's because of advances in science and technology, and also the fact that there are now platforms that have been developed because of investments in the last several years, which make it possible for companies and academic groups to just take the new virus sequence and put it onto an existing platform, which has already been tried and tested for other diseases. And this is part of the reason why we had a phase 1 trial of one particular vaccine 66 days after the first genetic sequence of this new coronavirus was made public. Now, having said that, vaccines still need to go through phases of testing. They need to go through lab testing, followed by animal studies, followed by human trials, starting with very small numbers of people to test safety, moving on to what we call immunogenicity studies, where we look for the development of protective antibodies and other immune responses, which we think are signals. But eventually you need phase 3 trials, which actually look at reduction of disease in the group that's vaccinated compared to the group that's not given the vaccine or is given a placebo. And this happens in tens of thousands of people who are also followed for safety signals. So no vaccine is going to be mass deployed before the regulators are confident and the governments are confident, and that WHO is confident that these vaccines have met the minimum standards of efficacy and safety. We have a very elaborate and thorough process where we look at all the criteria, the qualities of a vaccine, and whether they have been met before we will make any kind of recommendations, either on emergency use authorization or on a general licensing or authorization for use through pre-qualification programs. We have an independent group of experts, the SAGE, the Scientific Advisory Group of Experts on Immunization, that makes recommendations. Again, it's a globally recognized independent group of experts that will look at the properties of an individual vaccine and the data from the trials before they'll make a policy recommendation. So I think we should reassure the public that vaccines that are recommended for use by WHO and by the national regulatory authorities would have passed the minimum standards needed. We've also heard very encouraging statements from a number of the vaccine developers and the heads of those manufacturing companies that they will abide by the standard guidelines and rules for development of vaccines. So there needs to be, I think the questions that people are posing means that there is a need for more information sharing. There's a need for more transparency, for more education of the public on vaccines in general, and then on COVID vaccines in particular. Thanks.
Can I add?
Yeah, Dr. Tedros, please.
Thank you. Thank you, Fadila. I think Soumya had said it all. Just want to stress a bit. I would like to assure the public that WHO will not endorse a vaccine that's not effective and safe. So that's one. And second, as she had said, vaccines have helped in eradicating smallpox. Then almost on the verge of eradicating polio. But I would like to remind the world how we used vaccines to defeat Ebola in northern Kivu, eastern DRC, where the Ebola outbreak situation was effective, and safe. That's what I would like to assure the world. And as Soumya said, this will be done by WHO and local authorities. As to the anti-vax movement, they can build narratives to fight against vaccines, but the track record of vaccines tells its own story. And people should not be confused by a movement, anti-vax movement, but they can have a look for themselves on how the world actually used vaccines to reduce under 5 mortality, to save children, and to have successful eradication of diseases like smallpox. So just please go to the track record of vaccines and have a look for yourselves, especially parents. Have a look for yourselves and see how vaccines actually change the world. And that's why we have this famous saying, vaccines actually affect adults. Our children will be healthy adults when we use vaccines. And for COVID, we are hopeful that we will have one so that the world can get back to normal. Thank you.
Thank you, Dr. Tedros. We will move now to Simon Ateba from Today News Africa. Simon, can you hear me? Simon? Second attempt.
Yes, I can hear you.
Simon, we can hear you.
Yes,
Please go ahead.
Yeah, I can hear you. Thank you for taking my question. This is Simon Ateba from Today News Africa in Washington, D.C. Yesterday, WHO Africa said virtually all African countries, all 54 or 55 African countries, have expressed interest in Kovacs, the groundbreaking initiative to provide almost 220 million doses of vaccine to Africa. I would like WHO to give us an update on what the next step is and what will be the contribution of each African country to take part in Kovacs. And also to ask WHO if 220 million doses of vaccine for a continent that has 1.2 billion people is enough. Thank you.
Thank you, Simon. We will start with Dr. Bruce Aylward. Bruce.
Thank you, Simon, and thank you for emphasizing the importance of the landmarks that we passed this week in the battle against COVID and getting our ACT accelerator up and operating. As you highlighted, this week we passed the landmark by the 31st of August. We were asking countries to confirm their intention to participate in the Kovacs facility, and as the Director General highlighted, we were delighted to hear that 78 high and upper middle income countries will be joining with the 92 countries of Gavi and that will receive support through what we call the advanced market commitment, for a total of now 170 countries that will be part of the ACT accelerator. The African continent has been a huge contributor to the work of Kovacs. As some people on the call will be aware, there have been a number of important partners that we work with in terms of trialing vaccines and studying vaccines, also in terms of planning how they would be rolled out and operationalized over time, also in the very design of the Kovacs facility. We've had a number of big conference calls that have involved many of the countries that are now signing up to Kovacs, many countries from the continent who are providing their input as we worked out the details of the Kovacs facility and designed it really together. So a huge contribution. And will continue to be as we go forward. Now, in terms of vaccine numbers and doses, remember the way that we've been discussing the use of these products that will come out of the ACT accelerator, especially the vaccines. Our goal, our immediate goal, is to reduce the severe COVID, the burden of severe COVID disease around the world. Because if we can reduce the risk of severe COVID disease, then we can very rapidly, as the Director General emphasized, start getting back to a more open societies, functional societies, and rebooting our economies. Because it is a severe COVID disease which is generating the fear, and it's a severe COVID disease which is resulting in the loss of confidence, and whether it's in terms of individuals, in terms of employers, et cetera, that underpin the economic challenges we face. So what we look at is how much vaccine do we need to reduce the risk of severe disease? And as was described in the opening comments of the Director General, we have a better and better understanding of who is most at risk of the disease and most at risk of severe COVID disease. So we don't need vaccines for absolutely everyone right at the very beginning. What we need to make sure is, as we've said before, all countries get some vaccine, and that we use that vaccine to protect our healthcare workforce and care workers, and then to protect our elderly, and then protect the others who are at highest risk. And that can be done initially with relatively small quantities of vaccine as they come out, and then grow over time. So the important thing is not what is the exact number, but how much vaccine do we need at the beginning to be able to reduce the risk of severe disease? Because that's the key to removing the fear, rebuilding the confidence, and getting our societies and economies working again. And the 200+ million doses would definitely go a long way to achieving that. But right now, we're a very long way even from that 200 million doses. So that's the key. It's been an important week, and we're certainly encouraged by what we're seeing, again, in terms of a tremendous solidarity to try and ensure we reduce that risk of the disease around the world and start getting back to a more normal way of functioning going forward. I think Soumya wanted to add.
Very briefly, just to add, I think Bruce has explained it very well. Just to add that the African Union has taken real leadership in this, and engaged with discussions with WHO, but also with other partners on making sure that there's access to the best vaccines for the African people, but also to be part of the development, part of the research and development process. And so the strategy for the COVID vaccines for Africa really has three pillars. The first one being very much to be playing a leadership role in the research and development of these vaccines, ensuring that clinical trials take place in Africa so that these vaccines are tested in different ethnic groups, different racial groups, age groups, etc., so that you have better estimates of how this vaccine works in different populations. Also focusing on expanding manufacturing capacity in Africa, getting into technology transfer and so on. This is building capacity for the future. And of course, focusing also on the policy, the implementation, how delivery of these vaccines will take place. As we know that many countries face a lot of challenges in delivery, even of routine vaccines to children. And this is going to be a vaccine that's going to have to be given to other age groups. This is not a childhood vaccine. So we're going to every country needs to start thinking about how these campaigns are going to be run and what is going to be needed in terms of human resources, supply chains, cold chain equipment, logistics, needles, syringes, etc., training, so that when the vaccine is available, that there's no delay in launching these immunization programs. Thanks.
Thank you, Dr. Swaminathan, and thank you, Bruce, for your answer. I believe Mike Ryan has something to add. Mike, can you hear me?
Yes, no, just to follow up, and I'm just speaking with specific reference to Africa and to colleagues in Africa.
Sorry, Mike, you are very soft. Can you speak out, please? Speak up.
Yeah.
Thank you.
Yes, can you hear me?
Yeah. Try again, Mike. Thank you.
Hello?
Speak a bit louder or maybe increase your volume. I'm taking the...
I can't speak any louder, otherwise I'm shouting. So can you hear me now?
You are great. Go ahead.
I just wanted to reflect on the contribution that African countries have made in general to vaccination, and to congratulate Africa as a continent for the eradication of polio and the certification of that eradication. A huge task carried out with many years of effort, and both Tedros in Ethiopia and our RD Dr. Weti and Bruce himself was sitting there, championed a lot of the work that led to that, but also in the areas of cholera, in the areas of meningitis, in the area of yellow fever and Ebola. African countries have championed a lot of the techniques we use now for mass vaccination, for community engagement, and for really going after infectious diseases, particularly these epidemic diseases. So Africa has a lot to also share with the world. It's not just a beneficiary in this process. Africa has learned the techniques of introducing new vaccines, quickly against epidemic diseases, and in innovating in terms of implementation, in terms of logistics. And again, Dr. Tedros spoke to the situation of Ebola. It was African health workers, African scientists who worked to bring the Ebola vaccine into the field, a vaccine that had to be transported at -80 degrees into the deep field and given with very stringent oversight and data gathering and safety measures. Again, a huge triumph for African public health. So in this, I believe African countries, and particularly African scientists and African doctors and nurses, have a lot to tell the world about how we can introduce a vaccine against COVID in an effective way and at scale. Thank you.
Thank you, Dr. Ryan. There is no other intervention in the room. I would like to give the floor now to Peter Schilling from the European News Agency. Peter, can you hear me?
Indeed, thank you. Can you hear me?
Yeah, very well. Go ahead, please.
Okay. With all the schools opening up in most of the European countries now, there's a very big debate what to do and how to handle children. I want to refer to a publication that was made by the Massachusetts General Hospital and the Child Hospital that provided critical data showing an alarming twist with children, that they likely play a much bigger role in spreading the coronavirus than we actually thought so far. So also that they were having a very high viral load. So the question is, to what extent should we then go through lockdowns when a class is identified with having a COVID-19 infection? Should we actually lock down, or should we contain the children in class for the period? Otherwise, they go back home and be spreading it more than we thought. Thank you.
Thank you, Peter. Dr. Maria?
Yes, thank you, Peter, for this really important question. So you highlight a study that has been recently published. And in fact, there are a number of studies now that are looking at three major important aspects of COVID-19 in children. One is the severity of disease, the disease that is experienced by children and adolescents. And luckily, most children have mild disease. Many children have asymptomatic infection. It's not universal. We do have reports of children having severe disease, and some children have died. The second thing we look at is the extent of infection among children. We've known from the beginning, and we have said repeatedly, that children can be infected with the SARS-CoV-2 virus. And of course they can. All people are susceptible to this virus. What we didn't understand and what we are starting to learn is the extent of infection among children. This is captured mainly through these seroepidemiology studies. And there are several studies now that have been published that look at the age differences in seroprevalence. What is important when we look at infection rates is we need to break the children down by age group, because there seems to be different rates of infection as measured by these antibodies in the youngest children, with lower levels of rates of infection or seroprevalence compared to adolescents. So they can be infected. The third thing that we look at is transmission. And are children capable of transmitting the virus? And again, from the beginning, we knew that children could be transmitting the virus. We learned this very early on from household transmission studies that were conducted in the early days in China, And what we were really concerned about in the beginning was, were children infecting adults, were adults infecting children? And we knew and we know that transmission can happen both ways, although in the beginning appeared it's more often happening, transmitting from adults to children. What we're learning about now is that, again, it's very sensible to look, and it's important to look at age differences in children, because there are different contact patterns among children. So in terms of transmission, the youngest children tend to transmit less. And if you just look at the type of contact patterns that they have and their ability to transmit. But adolescents do transmit, and they can transmit the virus, and they seem to transmit at similar rates to adults. So it's important when you consider what to do with children, and that was your question. You treat all people. We look at different age groupings. When we think about schools and we think about opening up schools, you've heard us say many, many times that it's important that we don't look at schools in isolation. Schools are part of communities, and if the virus is transmitting in communities, it can transmit in that school. But there is some importance to making conditions when schools are open for the youngest children compared to adolescents. We've outlined a series of considerations and guidance around how schools could open up safely. Everybody recognizes the incredible importance of schools, not only for education, but for security, for in some situations, for food and for their social and their mental well-being. And so it's very important to consider the type of school, the age group that's there, and the grades, their ability to comply and adhere to public health measures like physical distancing, the wearing of masks where appropriate, hand hygiene, all of the different factors that are part of opening up society safely. And opening up schools is included in opening up society safely. So we're learning a lot, but I do think it's important. We don't know everything as it relates to children, but there are a lot of good studies that are out there. And I think we all recognize the importance of keeping children safe, but it starts with the community. Bringing transmission in control in the communities is critical. All of the individual measures that you need to take to protect yourself, whatever age you are, from getting infected and to prevent you from passing to another is really important. Hand hygiene, respiratory etiquette, wearing a mask where appropriate, all of that. In addition to active case finding, isolation of cases, contact tracing, all of this needs to be as part of our new normal as we go forward.
Thank you, Dr. Baria. We have now a question from B.N. Kumar from India Biz News Connect. Kumar, can you hear me? Kumar?
Yeah, can you hear me?
Yes, very well. Go ahead, please.
Yeah. See, my question comes from the experience in India. For a long time, many leaders, politicians have been claiming that, by the year end or middle of next year, we'll have a vaccine, safe vaccine, etc. And on the other hand, we have a group of doctors cautioning that, not to make false promises, not to create false aspirations among the people about the vaccine. My question is, how realistic is to assume that the vaccine will be available soon, 6 months, 8 months? What kind of period that we can look at? Because it's creating a lot of confusion in the minds of the people.
Thank you, Kumar. I think this is a question for Dr. Swaminathan. Soumya, please.
Thank you for that question. As you know, there are a large number of clinical trials going on worldwide. We have more than 30 candidates now in clinical trials. About 9 of them are in phase 3 clinical trials. There are at least 3 clinical trials going on in India, phase 1 and 2 trials. So it's a very optimistic scenario because there's a huge field of candidates. And we know that normally in vaccine development, we expect about 10% success rate. And so to have more in the early stages of testing gives us hope that several of them would be able to be, prove themselves to be safe and efficacious. But as we said earlier, these need to go through the full phase 3 clinical trials before we can answer that question. We expect results from some of the candidates which are at already in phase 3 trials to come by the end of the year or the beginning of next year, following which there will have to be scaling of manufacturing to produce the hundreds of millions of doses that are going to be needed. In fact, the world is going to need billions of doses, and that's going to take time to manufacture. So we have to be optimistic and realistic at the same time. So realistically speaking, probably the second half, the middle of 2021, maybe the second quarter, third quarter of 2021 is when we can start seeing doses actually flowing into countries so that they can start immunizing their populations. And as Bruce was saying earlier, we're not going to have enough for the whole world, right at the beginning. We're going to see first tens of millions of doses, then hundreds of millions of doses, and subsequently, hopefully, that scale up will happen. So eventually there will be enough for everyone, but it will mean prioritization of groups within countries who should receive those first tranches of vaccines. And this is where the Kovacs facility and the fair allocation framework that's been developed by WHO in consultation and agreement with our member states would play an important role in determining how those scarce doses of vaccines in the beginning will be distributed and used, hopefully in a fair and equitable manner. So that, as the DG was saying earlier, it is important to make sure that the people who need the vaccines get it, regardless of which countries they're living in. There's no point some countries vaccinating entire populations while others are waiting for a long time. So that's what the Kovacs initiative and the Kovacs facility aims to achieve. And if it comes sooner, the better. But certainly by the middle of 2021, we should start seeing some vaccines actually moving into countries and into populations. Maybe Bruce wants to add.
Thanks. If I just may add one thing, just to supplement what Sumi was saying about the advancement of the vaccines, I just want to make it crystal clear. There's so much that we can do now. While the vaccines are being accelerated and being developed, and it's been outlined very clearly that it's a safe and effective vaccine that is so much of the world is working towards, and that's really wonderful. But there's so much that you can do now. And I think we will hammer this as much as we possibly can, because there are individual steps that you as an individual can take to protect yourself from getting infected, to minimize your exposure, to manage your risk. This has to do with how you live your daily life. And everybody wants to get back to, a normal life and get back to what used to be, but we need to make considered decisions about how we go about doing that. How we go to work, if we need to wear a mask where we can't physical distance, we need to practice hand hygiene and respiratory etiquette, avoid the 3 C's, these crowded spaces and closed settings, especially with poor ventilation. There are ways in which you can minimize your exposure, and to be informed. So what is really important is that you know where the virus is in the areas where you live and in the areas where you work. And this comes from the strong government-led responses that we are seeing in so many countries. The strong, clear response at a national level implemented at the local level. What we are seeing now is countries that, in the beginning, many had to put in these national lockdowns, because so-called lockdowns, because they needed to buy themselves some time to take the heat out of the virus, out of the transmission, and get some time to get their systems on track. Many countries have a public health workforce now. They have testing capacity that has been greatly increased. They have contact tracers that are out there, that they're preventing clusters from happening, or when clusters do happen, they're rapidly carrying out these outbreak investigations. All of these things are really positive, and I just want to highlight this because we are seeing many countries apply these public health measures and taking at great effort and bringing outbreaks under control. And these are things that are happening now. So we need strong government-led responses. We need very targeted, tailored local implementation so that we could avoid national lockdowns again. And we are very hopeful, and we are seeing in many countries they're applying targeted, time-bound, geographically bound measures to bring outbreaks under control, and using all of the active case finding, contact tracing, training your workforce, protecting your workforce, improving clinical care, getting hospitals ready. All of that is still happening in the background. And countries that have been successful in suppressing transmission are ready. They are ready to identify cases very quickly. They're ready to identify clusters and carry out the necessary steps to prevent those clusters from becoming community transmission. So I just want to emphasize that there's so much that all of you are doing now that is benefiting society and is helping this pandemic. So please, be hopeful and be empowered that there's a lot that you can do.
I think Dr. Bruce has something to add. Bruce?
Yeah, I think just to help Mr. Kumar, that was an important question. I think it's hard for the general public when they're hearing these sometimes substantially different assessments of how long it will take us to actually have a successful vaccine, and if indeed these trials are successful. And sometimes it's helpful to demystify these timelines a little bit. But if you think about these trials, what you keep hearing, phase 3 trials, remember these involve tens of thousands of people. Usually the large ones we really need to see an effect of the vaccine on. You have to give people one dose, and then usually it's at least 2 weeks or 3 or 4 weeks before they get the second dose. And by the time you enroll that many people, get those 2 doses in, that's often 3 months or longer. And it can't be shorter than 2, obviously, but it's usually a few months just to get that many enrolled in the trials. And then you've got to observe them for a long enough period to understand who is protected and not protected. So, and there you're a little bit at the mercy of the epidemic itself, because it depends on how much disease is actually circulating in the community by that point. And then when you finally have that, which will take a couple of months, a few months, depending on the intensity of transmission, then you've got to analyze those data. You've got to get the product licensed. Now, there's some things we can do to speed things up. We can, if we think it's a very promising vaccine, we can produce it in parallel at risk. Even if it fails, we'd have to throw those doses away, as you've heard. But there are other things you simply can't speed up. And this goes back to the important question asked earlier, if I remember it was by Anna, I believe, about the vaccine confidence. We can accelerate many parts of the process, and we'll work very, very hard to do that. Scientists, manufacturers, everyone is doing their best. But you cannot accelerate certain parts which are essential to ensuring the vaccines are safe and efficacious. That takes a certain amount of observational time that you simply can't rush. And it would be in no one's interest to rush that part of it, because that is what would shatter the confidence and trust, which is so important in this process to roll out these vaccines. So when you stop and think a little bit, these phase 3 trials, how big are they? They're going to give 2 doses up to a month apart, and then they're going to have to follow those people for some time. You can understand why these timelines can be fairly long between now and when we have a definitive answer. And also, some of the factors are simply out of our control because it will depend on how intense transmission is in an area.
Thank you, Dr. Elwood. I think we will wrap up now the press conference if there is no other intervention in the room. Maybe Dr. Bente wants to add something?
Thank you very much, and thank you for also focusing today on the chronic diseases. And of course, the primary task just now is to defeat COVID-19. But at the same time, I think we cannot ignore, as Dr. Maria as well says, that we have to work to really to treatment, and we can see that cancer diagnosis really are suffering. but also the Lancet article focusing on the universal health coverage tells us that we will not be able to reach this without also including non-communicable diseases. And the publication today from the Lancet Imperial College, WHO and NCD Alliance show us that we need to work much harder. So I think, if I may add, I think really to learn from this pandemic and build back better, and we cannot continue the same way because a new pandemic will again really also be
Final words, Dr. Tedros. Thank you.
Thank you. Thank you, Fadila. Thank you for moderating today. And I would like actually to use this opportunity to thank Margareta for moderating the past few months. And today is Friday, so I wish you a nice weekend. And in this room, I have many colleagues here with me. And I just would like to introduce actually the countries they come from. Maybe I'll start from the moderator. Is from Algeria. And then I have Australia, Canada, Poland, Serbia, India, the United States, Norway, the United Kingdom, Lebanon, Afghanistan and Netherlands, Ireland, France, and of course myself from Ethiopia. So that's the diversity we have in WHO. And I'm really proud to be WHO. And it's the whole world which is serving you. And thank you all for joining us. And please accept our happy weekend from all my colleagues, representing almost the whole world, as I have just read where they come from. We are the world. And national unity and our solidarity is the antidote to this pandemic. Thank you so much again. Have a nice weekend. Bye-bye. And see you on Monday.
Thank you all. Bye.